Welcome, everyone, and thank you for tuning in today. My name is April Tepfer, and I wanted to talk to you today a little about having some trepidation after trephination, especially in regards to flight considerations in the pre-hospital air transport world. The outline I have for today is to give some background on trephination, especially some interesting historical context, as well as current procedures. Additionally, I wanted to present some considerations for the air medical transport of patients after they have been trephinated. So to start with a patient case, you're an air medical transport service dispatched to a rural hospital for a 58-year-old male patient who was involved in a motor vehicle accident earlier in the day. Of note, the patient was not seatbelted and there was significant damage to the windshield of the car. Upon arrival to the ED, the patient is noted to be hypertensive to the systolics over 200. The ED provider's report for the patient is that they were diagnosed with an epidural hematoma that was evacuated using a burr hole, and there were additional concerns on the head CT that are going to require further neurosurgical intervention. The patient has been accepted to the university hospital by their neurosurgical practice, and your job is simply to fly them there. So the question I have for you to think about is, do you have any concerns about flying this patient? Given that patient case, I hope there were some questions that came to mind. One question might have been, what is trephination? Well, to give a little historical perspective, trephination is believed to have been the first neurosurgical procedure to have been practiced. Examples exist as far back as the Stone Age of skulls that have not only been trephinated, but had healed from the act. In the Neolithic time period, trephination is thought to have been practiced to bring back to life, or the effect of resuscitation, specifically on predominant members of the tribe who were considered dead by their own primitive conception of death. In the Aztec populations, trephination is believed to have been a rite of passage. Young members of the tribe, predominantly males, were trephinated by the elders, and if they were survived, they were welcomed into adulthood. There have been predominantly 4 methods documented throughout history to trephinate a human skull. They include what is depicted here in the image, with number 1 being a scraping action, 2 is a grooving action, 3 is boring or cutting, and the 4th one is the rectangular intersection cuts. The current practice of trephination has really just introduced additional terminology. The term trephination is used almost synonymously with trephination as well as burr hole. The term trephination comes from the Latin term trephines, which means 3 ends, and is referring to the historic trephine that was used in the 16th century to perform the procedure. The word trephin comes from the Greek term for boring, as in the act of boring into the skull. The newest terminology is that of burr holes, which I assumed was named for a physician who had perfected this technique, but it is not. Sadly, there's no Dr. Burr. Rather, when referring to burr holes, the term burr refers to the surgical technique of a rotating cutting instrument that can be attached to a drill, and the term burr hole is a descriptive term for a small, round opening made in the skull using that surgical drill. In general, all these terms refer to creating an opening, typically in the skull, made to access the brain for various medical procedures, such as brain surgery, draining of a fluid collection, or obtaining tissue samples for biopsy. So what does cutting into the head mean for flight considerations? Well, the literature on this topic is very limited. The first research article I found on the topic was entitled Air Travel After Intracranial Surgery, a survey of advice given to patients by consultant neurosurgeons in the UK. This study questioned 66 neurosurgeons in the United Kingdom regarding advice given to patients regarding air travel after intracranial surgery. This study asked neurosurgeons about the advice they gave to patients, since the concern is the associated risk of pneumocephalus. The results were really interesting to me. Of the 66 responding neurosurgeons, 61 of them advised their patients not to fly postoperatively, which left 5 of them giving no advice on air travel in the postoperative period. So of those 61 that advised their patients not to travel postoperatively, only 35 of them had a specific time period in which they advised patients not to fly. But even more interesting was that that time frame ranged from less than 2 weeks to greater than 8 weeks postoperatively. Additionally, of those 61 neurosurgeons that advised their patients not to fly postoperatively, 42 of them were primarily concerned with pneumocephalus, while 3 of them had a primary concern of DVT. So as critical care transport professionals, should we be concerned about pneumocephalus? The only study I was able to find that was specific to air medical transport was a simulation study from the Scandinavian Journal of Trauma, Resuscitation, and Emergency Medicine published in 2017. This study was focused on post-craniotomy patients that were requiring air medical transport to their home hospital. The concern for these patients was regarding intracranial air on the flight levels or cabin pressures that these patients would be transported, given that PV equals nRT. The methods that were used in this study was a patient population that was post-op from evacuations of subdural hematomas. CT scans were used to determine intracranial air volumes, and then flight simulations were used to test multiple different cabin pressures to see what the resulting change in the intracranial air volumes would be. Results from this study were of the 119 patients, 40 of them had intracranial air postoperatively. In the simulations, it was determined that patients that had less than 11 mils of intracranial air were unlikely to develop intracranial hypertension, but those that had greater than 11 mils of intracranial air would likely develop intracranial hypertension. If the cabin pressure was maintained at the ground level pressure the patient had during surgery, the risk of developing intracranial air pressure or hypertension was reduced. So in going back to the patient case that was presented at the beginning, the question still remains, do you fly this patient or do you recommend this patient be transported by ground? I don't know that there's a right answer in this case. It will depend on your local protocols, but it is something I would make sure that the accepting neurosurgeon is aware of and default to their assessment of the situation. Thank you for your time and attention today. Here I include my references. Thank you.